Hello, everyone. Thank you for joining us, and welcome to our webinar this evening. It's our Skin Chat webinar on pH and skin barrier, a forgotten concept. As speaker this evening, we have Dr. Leon Kircik, who is clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai, New York, and Indiana University Medical Center in Indianapolis, as well as medical director of physician skincare, derm research, and skin science in Louisville, Kentucky. From Canada, we have Dr. Charles Lynde, Medical Director, the Lynde Institute for Dermatology and Lynde Derm Research, as well as Associate Professor, Department of Medicine at the University of Toronto. We would like to thank tonight CeraVe that has been kind enough to make this educational event possible. Now, before we begin, just a couple of technical tips. If you're having issues hearing the webinar, you can listen to the presentation using the telephone. Just select phone call and the audio pane on the dial-in information will be displayed. If you're having technical issues or if you want to ask questions to our two speakers this evening, you just go on the right-hand side of your computer in the question chat pane and type in your questions. We will be answering questions at the end of the seminar if time permits. At the end of the webinar, you will be receiving a survey in about 1 to 2 days. If you could fill in the survey and send it back to us, we would be truly appreciative. And finally, 1 or 2 days after this seminar, you will be receiving the recording as well as a certificate of attendance. Again, if you want to ask any questions, just go on the right-hand side of your computer in the question chat pane and you can type in your questions. So without further ado, I would like to pass the floor virtually to Dr. Leon Kircik.
Good evening, everyone, and thank you for joining us tonight. And greetings from Montauk, New York, where I've been hiding lately. So for the next hour or so, we will be discussing the role of the skin pH and skin barrier function. And the concept of the acid mantle has been around for a long time. It's actually a historical topic. I remember going back 30 years to my residency years, my professors and teachers in the clinic, they used to write all these concoctions with the acid mantle base for hand protection, for people who work with chemicals and contact dermatitis, hand dermatitis, you name it. But lately, it has been forgotten. And despite the fact that we have a lot of scientific evidence, ample amount of evidence tying the concept of the acid mantle to the epidermal barrier, as well as microbiome, as well as the functioning of the lipid lamella, as well as the epidermal barrier function. So we have a lot of evidence tying the importance of acid mantle, but unfortunately, there is a lack in the clinical care concept of the acid mantle in the clinical care. So we're gonna discuss that tonight in depth. Next slide, please. So before we do that, we're gonna take a polling question. And it's a reminder, let's see how many of us is gonna remember what is the physiological skin surface pH. Please select the answer. Okay, and the answers are, well, almost 65% of you guys knew that the physiological regular skin pH is acidic and 4 to 6. Can we move on to the next slide, please? So when we look at here, the normal skin pH, we already know it's 4 to 6. But what happens when we wash our hands and when we use a soap, regular soap, nothing fancy, right? The pH is about 10 to 12. It's very, very alkaline. And now we add to that, what do we wash our hands with? Tap water, unless we're using Evian. So then that pH is somewhere around 7 to 8.5. It's neutral pH, more on the basic side. Right here and then, we already destroyed the acid mantle of our skin on the hands if we're washing the hands just by using a soap and tap water. Right there, we already destroyed it. So let's take a closer look at this a little bit more. As we go down from the top to the bottom of the stratum corneum, the pH also goes up inversely about 0.2 to 0.3 units. At the bottom of the stratum corneum, it's about 6.8. So what does all this mean? So the interplay of the stratum corneum, the natural pH, to the epidermal barrier, to the skin microbiome diversity, the lipid processing, it's an amazing process. There are things that's going to impact the skin pH from outside, just as I mentioned, simply by washing hands with tap water and soap. But there are also things that endogenously the pH plays an important role, and there's an interplay between that the pH, the acidic physiological pH of the skin, with the lipid processing enzymes, as well as the epidermal barrier and the breakdown of the corneodesmosome, which I'm gonna discuss it in depth, as well as the skin microbiome. But we're not gonna discuss skin microbiome tonight in depth, just very briefly. So let's take a look at the a better look at here to the stratum corneum. And as you know, stratum corneum, we always thought that stratum corneum was a bunch of dead cells, pile of dead cells, right? Until recently. But now we know that actually stratum corneum is a living, dynamic organ that has a lot of functions. And one of the most important functions is it's antimicrobial and it has an immune response. If you think about it, innate immune system, the antimicrobial peptides, actually is the function of the innate immune system is the part of stratum corneum function. And this is the first defense against everything outside that happens. It's almost, think about the TSA at the airport, right? When you go through the airport, well, nowadays we're not going to the airport anymore, but when we used to, the first thing is that the TSA people check your luggage. I mean, your handheld luggage, right? The same thing here, innate immune system is part of that stratum corneum function, which is very, very important. Let's take a closer look here. So that epidermal barrier, the stratum corneum, looks like a wall, which is the part of that wall are the bricks, which is the corneocytes, and then part of it is the mortar, which is the lipids, right? This is very well known already. Let's take a closer look though. When you take a closer look, so the wall, the bricks are being held by that lipid lamella in between, right? That's your mortar, but also it's being held by the nails between those bricks, the corneodesmosomes. So this is very important, and it's going to become crucial in understanding how the interplay between the pH, the corneodesmosomes, as well as the lipid lamellar formation play a role. So let's take a look at first the corneocytes. Inside the corneocytes, we have the natural moisturizing factor, and they are basically low molecular weight, highly water-soluble hygroscopic molecules that come from the cleavage of the filaggrin. Now, here's the deal. If you remember, atopic dermatitis patients, the kids, most of them have inherently filaggrin deficiency. Guess what? No filaggrin, then no byproduct of the filaggrin after the cleavage, so they have a dry, scaly skin. So that makes sense, right? And Dr. Lynde is going to discuss that in depth a little bit later. So when you get that filaggrin cleavage, what's left is 40% uracanic acid, 12% PCA or pyrrolite carboxylic acid, and 3 amino acids, okay? Now, let's take a look at the corneodesmosomes. Remember, those are the nails, but they are formed of different stuff, desmoglein, desmocholine, and corneodesmosin. And that is going to become very important again when we consider the acidic pH of the skin. So, but now let's take a look what's between those corneocytes, the lipid lamellar bilayer, mostly formed of 3 types of lipids, ceramides, free fatty acids, and cholesterol. Tonight, we're going to concentrate on the ceramides. So when you look at those ceramides, they are basically covalently bonded to the outside of the corneocyte envelope. They form the lipid monolayer. But then when you stack them on each other, that becomes as a template to organize the lipids into the lamellar bilayers, and hence playing almost a barrier, playing a role that's a barrier for the prevention of the moisture in the corneocyte that we already discussed. So when you don't have the lipids, you have a problem because that barrier is lost. Let's take a closer look at the lipids here. What are they? As I mentioned, mostly they are ceramides that we're going to be discussing tonight. Some cholesterol, 25%, and about 10-20% fatty acids. When you look at the ceramide structure, it's basically composed of the fatty acid and a sphingosine. Okay? It's a combination product there. But are they already there? Are they already in stratum corneum? No, they are not. They come from precursor lipids. What are the precursors and what happens? So the precursor for ceramide is glucoceramide, and that's being converted by an enzyme called glucosyl cerebridase. And then fatty acids are being converted by phospholipase from phospholipids, and cholesterol comes from cholesterol sulfate, and the enzyme that converts them is steroid sulfatase. Why am I mentioning those with these weird names? Those enzymes are very, very important because they play a role in the skin pH, and the skin pH, I should say, plays a very important role in the stability of this enzyme. So that's what we're gonna look at now. So let's take a look at first, in order to get this is a whole complete picture, look at the healthy skin barrier, right? We've already discussed the natural moisturizing factor that's coming from the filaggrin, and filaggrin is coming from filaggrin. Then, when you look at these blue boxes, consider each blue box is a corneocyte with the envelope around it. And those blue boxes now, each corneocyte is held together by the nail, which is corneodesmosomes, right? So they are actually can be degraded by degradatory proteases. Those proteases, such as called calligrain 5 and calligrain 7. Calligrain 5 is also known as stratocorneum tryptic enzyme, and calligrain 7 is known as stratocorneum chymotryptic enzymes. Here's the deal. They function at higher pHs, at neutral pHs, not acidic. So when the pH is low, at acidic pH, they are not going to do anything. They are not going to function, and they are not going to degrade the nails here. By the way, they do that by degrading desmoglein 1, okay? And then when that happens, the whole stratum corneum is going to break down, and you start the scaling and the desquamation. Next is, let's take a look at the lipid lamellar bilayer here, and that's going to be the last box. And here you go. You need to form the lipid bilayer, right? So you need to process the lipids to form that bilayer. Remember, they were coming from these enzymes that they convert the precursor lipids to the active lipids. So what happens, and those enzymes, by the way, they are stable at acidic pH. So you need them at acidic pH in order to convert and have those lipids. So what happens, let's go next. And next slide, please. So what happens, press one more time, please. So what happens when the pH goes up? So basically, let's take a look at neutral pH, 7.4. At 7.4, beta-glucoceramidase, which is the converting enzyme, is 10 times lower than at acidic pH. So basically, they are lazy. They don't want to do their job, and they're sitting there, and they're not converting the glucoceramide to the ceramide itself. So one more time, please, if you can click on it. So when you see the pH, high pH, so your enzyme activity is low, your lipid processing is low, and hence you don't have the lipid lamellar bilayer. That's it. So you lost the mortar now, okay? So you lost the mortar, but remember, you still have the nails. Next slide, please. Next slide, please. So let's take a look at the nails, okay? So what's happening here is now the pH is neutral, right? 7.4. What did I say? The degradatory proteases, the Kallikrein 5 and Kallikrein 7. They love the neutral pH. So now they're gonna get activated. They're gonna get to work. When they get to work, what are they gonna do? They're gonna basically start degrading the desmoglein 1, which means they're gonna break down the corneodesmosomes. So now the nails are breaking down. Next slide. So now look at the dry skin and you look at the healthy skin. At the dry skin, the moisture is gone in the corneocytes, your nails are broken, and you have altered protease activity because the nails are broken, and then you have reduced levels, including reduced ceramide, so your mortar is gone. So next slide. So what happens now? Click one more time, please. So when that, one more time. So when the pH is high, your serine protease activity is high because they love that neutral pH. The desmoglein degradation is high, and you're losing your corneodesmosomes, and now you're losing the whole integrity of the wall. So basically, next slide, please. So what's happening here now? You not only destroy your mortar because you're not making lipids, you also break down the nails, and that's it. The wall is collapsing. So your epidermal barrier is gone, the hemostasis is gone. What does that mean? That means now you're open to invasion. Look about the thing about the old cities, right? Medieval times. How the wars are won. If you guys ever watched the Game of Thrones, right? So the whole wall is broken around the city. Mortar is gone, nails are gone, and the enemy is gonna come in. Who's the enemy? The invasion of the allergens, but more importantly, invasion of the by bacteria, virus, fungus, by the way, including COVID, right? So now you are more prone to get COVID because of the lack of the epidermal barrier and the integrity of the skin. So think about that, which is very relevant nowadays, right? But even without the COVID, the whole bacteria, virus, fungus is gonna come in. Next slide, please. So now, this is all happening because of the pH is going up. And it's not even going that much up, right? It's just neutral pH, but it's going up. So we have a problem with the wall. We have a problem with the epidermal barrier. We have a problem with transepidermal water loss. We are losing moisture. But also we have a problem with inflammation. And the inflammation is not because of the vicious cycle of the dry skin getting irritated. Not only that, but also remember those enzymes I mentioned, kallikrein 5 and kallikrein 7, they actually activate pro-inflammatory cytokines such as IL-1 beta. Here now you have another problem. So you have the whole inflammatory cascade is going up. And that's what happens in atopic dermatitis. Next slide, please. So there's one more problem that I said we're just gonna touch upon it, the skin microbiome. If you can please touch one more time, click one more time. So you know what happens, right? With the epidermal barrier dysfunction, everything is coming in, all the invaders. So now the wall is broken, the invaders are coming. What's the biggest invader here? Staph aureus and strep pyogenes. And what is that gonna do? That's gonna mess up the whole skin, the microbiome diversity, and that's called dysbiosis. Remember that keyword. Click one more time, please. That dysbiosis is the key word here. So now we have dysbiosis, the microbiome diversity is gone, Staph aureus, strep is coming in, and the locals are all worried about it. Next slide, please. And that has something to do with the pH too. Number one, the acidic pH is very, very hospitable for the microbiome, for the locals, but very, very not hospitable, not welcoming for Staph aureus. But Staph aureus, they love, all pathogenic bacteria, they love the neutral pH. So again, here as we go, a little bit of pH goes up to neutral. Now we not only messed up the wall, we got the invaders in, and the invaders are welcome because remember, Staph and strep, they love that neutral pH. They thrive in the neutral pH, but not the acidic pH. And that environment now is hostile to the locals, to the local microbiome, because they like the acidic pH. So a little bit of movement, not more, right? Two units movement from 5 to 7 is causing all this mess. It's almost like the perfect storm, just with 2 units of pH moving from acidic to neutral. Next slide, please. And this is what all it happens in atopic dermatitis. So there was a whole Canadian group of dermatologists. They got together and they published the importance of the pH, skin pH, in inflammatory dermatological conditions, including atopic dermatitis as well as acne. And I was actually the guest editor for that in the JDD publication. And the whole point is that the consensus on that, next slide please, that skin pH, acidic skin pH, plays a very important role in skin barrier hemostasis, which is a key factor in atopic dermatitis, as well as other inflammatory diseases, including acne. And that's where I'm gonna stop. And next slide, please. Dr. Chuck Lynde from Toronto is gonna discuss the atopic dermatitis and the acne. However, before we go there, I just don't want you to forget the acid mantle. Click one more time, please. Because as I mentioned, we see how important it is. So I thank you for your attention. Click one more time, please. And then let's move on to the next slide. And on the next section, Dr. Chuck Lynde is gonna discuss what I discussed in the pH, the skin pH, and how it plays a role in atopic dermatitis and in acne. Dr. Lynde is the medical director and of the Lynde Institute for Dermatology and Lynderm Research, as well as associate professor, Department of Medicine, University of Toronto, a good friend of mine. I call him a Renaissance dermatologist. He does research, he speaks globally all over the world, and then he still has time to see more than 100 people a day, and with a lot of grandchildren and family time. So Chuck, thank you for joining us. Take it over, please.
Thanks very much, Leon. Like you, I believe the sort of concept of pH and the acid mantle has been kind of forgotten. And I think as dermatologists, we need to kind of bring that concept of what is old is new again. And that's why I convened a group of interested dermatologists in Canada, key opinion leaders from coast to coast. These included academic dermatologists, community dermatologists, pediatric dermatologists, to kind of review the literature and come up with this. And we set up and took two inflammatory dermatological conditions, atopic dermatitis and acne, to look at what's in the literature. And then we came up with consensus statements out of that. And that's basically that if you have cleansers and moisturizers close to that physiological skin surface barrier of 4 to 6, this may support increased skin barrier repair, decrease the inflammation in these particular conditions, accelerate pH recovery, increased antimicrobial defense. And again, one of the things that we noticed when we were kind of researching all this, that a lot of cleansers and moisturizers actually have a high pH, and this is not disclosed at all on the label. And these high pHs will damage the fragile skin barrier in disease states. This was the group that put together, and as Leon said, this was actually published in the Journal of Drugs and Dermatology, and Leon kindly agreed and wrote an article and editorial about this. So we'll start with atopic dermatitis, an extremely common condition that all of us see as dermatologists. I certainly see it many times a day in my office. We're doing a lot of different clinical studies in atopic dermatitis. It seems to be our understanding of the immunology is increasing. And I want to talk about it sort of in context about how pH in atopic dermatitis, the stratum corneum pH is important to the skin barrier. So I think we all know that AD is a common chronic relapsing skin condition, and there's an interplay between not only the skin barrier, the immune function, and the microbiome, and this is a very complex thing, and the contribution of all of these things contribute to this. A stylized cartoon, a very simple one, just showing that there are a number of risk factors that increase the pH. And certainly our Western society, the heating, decreased ventilation, changes the pH. the house mite exposure, and certainly frequent bathing, the use of a number of soaps that disrupt the barrier, and unfortunately some of the things that we use, some of the moisturizers and the cleansers that we use can also disrupt. Now, as I mentioned, it's certainly a complex situation. Certainly it's the skin barrier, it's the microbiome, and the immunological reactions that occur because of this are all very important. We know that flagrant and its degradation, as Leon or Dr. Kircik has said, are essential for maintaining this acidic pH of the skin. And this is just a kind of stylized cartoon that tells you in an ideal skin pH, you have increased ceramides, barrier function, you have commensal organisms, you don't have detrimental organisms such as Staph aureus, you have decreased serine production, decreased desquamation, and decreased Staph aureus and strep. And in the other side, if you decrease the flagrant by increasing the pH, you go the other way, and you end up having inflammation and immune dysregulation. So we all have known, this was actually, I think, a fairly seminal paper about this. Rawlings in the British Journal of Dermatology in 2014 reported on lipid abnormalities and atopic dermatitis. And there are a number of ceramides that are found in our skin. But I draw your attention particularly to the ceramides 1 and 3 that seem to be ones that are particularly abnormal in atopic dermatitis. And the study was basically done against healthy controls and patients with atopic dermatitis. And he found high levels of expression of glucoceramides, sphingomyelin deacrylase, all these big words that we have in dermatology, And these are not upregulated in contact dermatitis, actually, interestingly. And sphingomyelin hydrolysis was 6 times higher in non-lesional atopic dermatitis skin versus healthy age-matched controls. And I think if you've read any of the guidelines, and certainly the Journal of the American Academy, the American guidelines, they basically say the cornerstone for all treatment of all atopic dermatitis is moisturizers. And I'm here to say tonight that basically Leon and I, or Dr. Kircik and I, believe that using the right moisturizers, the right washes are very, very important. And even in the guidelines from the American Academy, for mild atopic dermatitis, moisturizers by themselves can be enough for a lot of people. This was a kind of a recent guideline. It's with an algorithm that was developed by a number of Canadian dermatologists. And again, as you note there, education and moisturizers for all types and everything is extremely important. And so skincare education, key part of prevention, the maintenance and treatment of atopic dermatitis. So we'll have a little polling question. And again, many available soaps and cleansers have a pH which potentially disrupts the skin barrier. Is this true or false? And everybody can vote. I think everybody's probably already kind of getting the idea here, but we're going to give you your chance to have your vote. Wow, okay. So the people are getting the message here. Yes, absolutely. Many soaps and cleansers have a pH that is disruptive to the skin barrier. Again, not only for atopic dermatitis, in a few minutes we're going to talk about also for acne. So they have a number of things, and this disrupts the skin barrier. And again, the Dr. Elaine Larson of Columbia University says this, and this causes changes through the microbiome, decreased antimicrobial capacity, and ends up potentially increasing the inflammation of the skin. And I just draw your attention, regular soaps have a pH of excess of 9. Again, Syndep bars containing synthetic detergents are okay. Certainly these combi bars with soap-based detergents and synthetic detergents aren't okay. Liquid cleansers, not bad, but they're not good either, because their pH is usually greater than 6. So you want to have gentle lipid-free cleansers or ceramide-containing cleansers that do not contain soap, and they have a pH of 5 to 7. And again, a cleanser with a polymeric surfactant complexes, again, pH 4 to 5.8 are even better. And so basically, this was another consensus statement we had in that particular article. Again, the cleansers and moisturizers having a physiological skin surface pH of 4 to 6 allow for skin barrier repair, decreased inflammation, pH recovery, and increased antimicrobial defense. And again, this is, again, a central thing, I think, on with our increased knowledge about this defective skin barrier, I think we should be thinking more and more about pH in our moisturizers and our washes. And again, this is, I think, is extremely important, again, in our babies, dealing with them. And again, daily moisturizing with the proper moisturizer, again, is certainly a cost-effective preventative strategy and goes along with our ideas of treating atopic dermatitis. And there's a lot of clinical support, and Leon is, or Dr. Kircik again, is going to talk about this subsequently. There's been a number of papers in the literature talking about this. And we now have complete emollient therapies, again, leave-on emollients, shower products, bath products, hand washes, shampoos, even nappy wipes that can potentially use that have ceramides and have the proper pH. So in conclusion, for the atopic dermatitis part, again, we have 3 major concepts that basically having a proper skin functions, proper skin barrier is extremely important. A pH imbalance, it disrupts that barrier function, and we should be using a proper topical cleansers and moisturizers. And this is an easy, cost-effective thing that can add as an adjunct to any of our other therapies that we use for atopic dermatitis. So we'll switch over to acne, and this is again a common problem that we all face and we see in our offices. And again, we're going to go over the concept of this about skin barrier function and pH here, and whether there's a barrier defect in acne. I think you all know that, in fact, that this is such a common disease. It's been thought to be the 8th most common prevalent disease globally. And we as dermatologists see a lot of these patients in our offices. So there are a number of factors involved in acne: inflammation, sebum hyperexcretion, follicular hyperkeratinization, Cutibacterium, which is the new name for Propionibacterium acnes, androgenic hormones, and skin barrier defect. And on the kind of right side of your screen, you see the follicular hyperkeratinization, sebum production. And this was kind of the older concept of acne. I think more and more we're understanding that the innate and adaptive inflammation is playing more and more a role, and we understand this is an inflammatory disorder, and we should be able to treat it in that fashion. And again, this is just a more cartoony type of thing. But again, if you see, again, the roles of each of these type of things, lipid quantity, lipid quality are important things in terms of this, and the adaptive immunity also. So is there a impaired barrier function in acne? And the answer is yes. Now, you have to go back to kind of 1995. A lot of people haven't been kind of going over and doing studies on this, but this was well shown in Archives of Dermatology back in 1995. And the answer is yes, there is an impaired barrier function in acne. And this is in acne by itself. These were people that were not being treated by any benzoyl peroxides, retinoids, or anything else. They were able to show that there's certainly an impaired water barrier dysfunction. And obviously that means that there's a barrier repair function abnormalities going on here. And again, this is just showing further that impaired skin barrier is caused by a decreased amount of ceramides, and that was found in that particular paper by Yakamoto, published in 1995. So again, functionally, in acne, the sebum excretion is higher, sebaceous glands are larger, there's subclinical inflammation, but also structurally, we're now seeing that there's increased flagellin expression, decreased free fatty acids, decreased linoleic acids, and again, decreased total ceramides, leading to a barrier dysfunction in this disease also. So is skin pH actually different in those? So we know there's a barrier dysfunction. Is the skin pH different in those with acne? And again, this was a small study. They did it with sebum levels with a sebum meter. They did pH levels, and guess what? They found out that in fact there is a abnormality in the pH, and the pH is higher in those with acne. Now, this was a much larger study in 200 controls, 200 those with acne, and they looked at pH levels, and this was published in the Journal of Clinical Aesthetic Dermatology in 2017. So higher pH in acne patients found in both genders, and you can see this scatter plot showing in the cases of acne, the blue on the upper panel and the red on the lower panel. And you can quite quickly see now the mean pH was quite different. So the mean pH in the controls was 6.35, or pardon me, 5.09, and in the actual acne cases was 6.35. Certainly, again, signaling a abnormality in the barrier function seen in acne. And again, these were people that weren't being treated with their acne, again, not with retinoids, not with benzoyl peroxide on board or anything else. So we're having another polling question. So which is not true? Higher skin pH is seen in males. Skin pH increases with age in females. Skin pH increases with usage of masks that we're seeing in this COVID era. And many skincare products and acne therapies disrupt the skin barrier. If everybody can vote. Okay. Can we see the results? Okay, so yeah, so just to reiterate, skin pH actually, I'm going to show you, increases with age in females. Skin pH certainly does increase with the usage of masks because of the disruption of the barrier. And again, many skincare products and acne therapies disrupt. Skin pH is not higher in males over females, but certainly is higher overall. We'll go to the next. So is skin pH different in acne patients due to gender or age? And this was in an article back in 2013 by Yoon. And they found actually that the females had a much higher pH in all facial zones, where there was T-zone, forehead, etc. So there's certainly a higher. This may account to why we often say that female skin is more sensitive than male skin in terms of this. There was an increasing pH with age in females. This was not seen in males. And again, just a negative correlation. So higher pH overall in acne, higher pH versus males versus or females over males was seen in a number of studies. So I mentioned earlier that many skincare products and acne therapies that we use probably disrupt this skin barrier even more. And this obviously has an impact on patient adherence and therapeutic outcomes. So having proper treatments are very important. So again, it's topical and systemic therapies such as retinoids, topical antibiotics, combination products, benzoyl peroxides can alter the barrier in a barrier that's already abnormal. And again, To counteract this, we certainly want to be using the proper cleansers and moisturizers. And again, cleansers and moisturizers close to the physiological skin pH, that 4 to 6 may reduce the skin irritation and improve the barrier function and ultimately improve the adherence to our other drugs. So education and moisturizing, very important. And as a conclusion in the acne section, again, think about using the cleansers and moisturizers, think about what you were doing in the skin, and think about pH. I turn it back to Dr. Kircik, who's going to talk further.
Okay, so let me thank you, Chuck. So what do we do? Let's move on to the next slide, please. And what do we do? We heard all those problems: atopic dermatitis, acne, right? We need something to fix the pH that causes the epidermal barrier. So we call the moisturizers to rescue. But unfortunately, not every moisturizer is the same, right? So what do we need? There are two simple basic things in the moisturizer that we need. One is an occlusive type of moisturizing, and the other one is humectant. Why do we need both? Well, we can have occlusive alone, but when you occlude the dry skin, there's really nothing to occlude. You're occluding dry skin, so it's not gonna do any good. If you just have a humectant, then the humectant, they basically attract the water from the deeper layer of the skin as well as from outside. But guess what? The moisture is gonna come and it's gonna evaporate as fast as it comes because you have a impaired epidermal barrier. That's where the tool studies comes in, right? Transepidermal water loss is high. The more water you bring in, the faster it's gonna go. So what do we need? We need both humectant to bring the moisture in, but then we need the occlusive moisturizer to occlude. That's what we need. So those are the two simple principles of moisturizing. And this is where CeraVe comes in. So what's so unique about CeraVe? And that's gonna be next our polling question, please. What is unique about CeraVe? Is it the ceramides? Is it the MVE technology? Is it the niacin in it, or none of the above? Let's go ahead and answer, please. Well, almost 2/3 of you guys said it's a ceramides, but there are a lot of other moisturizers that have ceramides in it, to be honest with you, right? So 1/3 said 31% ME technology, and that is true. That is a technology that we're gonna discuss. What makes the CeraVe unique? So can we move on to the next slide, please? So yes, the ceramides are there, but we also have niacin in it. Yes, that's also true, but there is something called multivesicular emulsion technology. Click one more time, please. And that technology does really make the whole CeraVe products unique. Next slide, please. As I always say, vehicle matters, not only in medications, not only in the prescription drugs, topicals, but also on over-the-counter, even the moisturizers. But first, let's take a look at the niacin. And there are a lot of products, other moisturizers that has niacin in it. But in this case here, the niacin does something extra other than moisturizing. It actually stimulates ceramide production inherently. So when you look at this study, which is very, very interesting, they had vehicle and they had niacin containing CeraVe. And here you can see that actually the niacin containing product increased the ceramide production statistically significantly compared to the vehicle. That include the not only ceramide but also cholesterol and free fatty acid, but mostly the ceramide, which was actually statistically significant. So that is very unique. But let's move on, please. So delivery matters as in the vehicle matters. Why does it delivery matter in this case? Next. Well, let's take a look at this emulsion technology, right? Multivesicular emulsion technology versus the regular emulsion. So the The emulsions are oil in water or water in oil. So in this case, it is a two-phase oil in water emulsion. But it's not easy to make that emulsion stable. And that is become stable with something called behenthromonium metasulfate or BTMS. BTMS is a cationic surfactant, and it comes from, actually it's derived from the rapeseed oil, which you see the flowers here. And the uniqueness of the BTMS that it is dispersible in both in water and oil at the same time. And that makes that emulsion, this oil in water emulsion, stable. But more importantly, the multivesicular emulsions has little vesicles, one in each other. So it's almost like a little onion that you peel and you peel and you peel. There is more and more in it. Or think about these little Russian dolls that they used to sell in Moscow on the streets, that you take the doll, open another one, open another, there's another little one, there's another little one, over and over and over. Next slide, please. So what's the big deal about that? Well, the big deal is that when you get a regular, next, click on please. 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 So what happens is when you have the regular emulsion, it's traditional burst delivery that you're gonna have everything out, all your ceramides or lipids or whatever you're delivering regardless in 4 hours or so. In this case, with the little multivesicular emulsion, when you have all these concentric spheres of oil and water, those are all unique, separate oil and water phases of all concentric spheres. It's like a multilamellar series that coming out and peeling one by one. Then you have that sustained release. And the concept is really not a brain surgery, because remember, we have all these kind of delayed release doxycycline, delayed release minocycline, right? We all have that, all that delayed release pills. So now you have a delayed release, sustained release moisturizer. That's the whole concept, that it keeps you moisturized for the next 24 hours. And you can see that multivesicular, multilamellar series in light microscopy. Click one more time, please. But also it has occlusive moisturizer. In this case, it's a dimethicone. By the way, dimethicone is not comedogenic. And then it also has humectant at the same time. Click one more time, please, which is glycerin in this case. So remember, the two basic principles are here. In addition to the basic principles, we have ceramides, cholesterol, and naturally occur physiologic-like lipids, in addition to hyaluronic acid, by the way, that holds its 100 times its weight. It's a great moisturizer, and the niacin. So all that in its entirety makes this moisturizer a unique one. Not each one differently, but it's all in contact with all of them at the same time. Next, please. So that's great, what I told you, but does it really work? As Dr. Lynde mentioned, there are a lot of clinical studies, and due to time constraints, we're going to discuss just a couple of them. Next. So the first one comes actually from Canada with Dr. Lynde's group, and that was, next please. So that actually looked at mild to moderate atopic dermatitis patients, absolutely no other treatments, right? And they used the ceramide containing cleanser and moisturizer, 2 cohorts here, and they used it for 6 weeks, twice daily CeraVe hydrating cleanser, twice daily CeraVe moisturizing cream, both on pediatric and adult patients. Next. And basically in both cohorts, next please. In both cohorts, the group 1 was the adult patients older than 12 years of age, and you can see that group 2 was the pediatric patients. All their AD symptoms improved. That's really the bottom line. And remember, this is without any treatment. Next. So speaking of treatment, really, next, when you treat atopic dermatitis, the mainstream treatment is still topical corticosteroids, right? We like them, we use them, they work very well, they work fast. However, we forget something. Next. The problem with the topical corticosteroids, even the short-term treatment, it actually compromises both permeability, barrier hemostasis, and stratum corneum integrity. Next, by basically it inhibits the steroids. Next, they inhibit the synthesis of the lipids and lipid lamella. They decrease epidermal proliferation and differentiation, and they also cause, of course, the stratum corneum integrity loss and corneocyte cohesion, hence the whole story that I told you before. So now we're using something to treat the problem, but actually we're making the main problem even worse. So what do we do? This is where when we have the moisturizer and the cleanser in order to deal with this problem, to overcome the steroid side effect, right? So next slide is actually next study. This directly discusses this scenario. This was done by Dr. Zoe Drelos, and basically they took mild to moderate atopic dermatitis patients and they divided them into 3 groups. Group 1 had the fluoxetinide cream, the topical steroid, right, with a cleansing mild bar cleanser. Group 2 had the same steroid but CeraVe hydrating cleanser, and group 3 had the same steroid, CeraVe hydrating cleanser, and CeraVe moisturizing cream. So I am sure you already know the answer, which group is gonna do the best, right? Next. So of course, group 3 did the best when they used both the cleanser and the moisturizer as a regimen. And we sort of inherently do this anyway, but this is a confirmation of what we're doing and what we should continue doing. But one thing it's really interesting when you look at the difference between group 2 and group 3, and group 2 just used the hydrating cleanser, you see the difference. It's almost double. The people who got better who got clear actually was almost from 36% to the 70-somewhat%. So basically, the use of the CeraVe moisturizing cream improves the results twice better. So that's pretty interesting. It doubles it. So we didn't think of that before. Next, please. So next slide, please. So the next slide is also about the acne. As Dr. Lynde mentioned, and he did this study, he and his group, they used ceramide-containing moisturizer with basically acne treatment. And the result, again, as we already know, next slide, please, that ceramide-containing moisturizers may help, click on please one more time, may help basically improve the treatment results and increases the adherence and complement the existing acne treatments, because remember, most of the acne treatment, as we already know, in itself is destructive to the epidermal barrier, especially topical retinoids, right? And then people stop using it. So in this way, if we can prevent that irritation, then of course you're gonna increase the adherence and you're gonna help the epidermal barrier. Next, please. So how do we do this? Why is CeraVe unique in addition to its ingredients and delivery system? Well, it's unique when you look at the click on please CeraVe hydrating cleanser bar or the SA cleanser. It's actually the pH is 5 here. So it's one of the lowest pH cleansers. So I think the whole thing falls into its place now, right? Because remember the very beginning slide I showed you, the soap is about 9 to 12 pH, and then the tap water is around 7, and you cannot help the tap water, you cannot change it, but you certainly can help your changing your cleanser and the moisturizer, especially with a lower pH than using a regular soap with a high pH. And that's certainly that simple basic advice to our patients with atopic derm, with acne, with any inflammatory skin condition is really going to help to restore the pH back down to acidic levels and then help to repair the epidermal barrier. Next, please. So in summary, next, please click on a couple of times. So we have the CeraVe cleanser and moisturizer that is a unique ceramide blend with the multivesicular emulsion technology, the special ingredient with dimethicone, glycerin, occlusive, and the humectant moisturizers, as well as we have all the backing scientific data, not only to the in vitro, but as well as the clinical studies that I mentioned, some of them. Click on, please. So I think I will stop here. And next slide, please. Next, please. So I thank you for your attention. Click one more time and we are almost done. If you have, we're gonna take some questions. We're right on the 9 o'clock dot. But if you have any questions, you cannot, please write to me at wedoderm@yahoo.com. Thank you so much.
So thank you so much, Dr. Kircik and Dr. Lynde, for that very informative presentation. I just want to remind you that you'll be getting this recording. You can also find it on the cerave.com website as well as the RBC Consultants website. So if you want to ask questions, go ahead and ask questions. You can always ask questions on the pane or info@rbcconsultants.com, or several of you know me at roxanne@rbcconsultants.com. So here are a couple of questions from the audience. Interesting one. Why do you think that acid mental, or the concept of acid mental, got lost?
Chuck, you want to take it or you want me to take it? Sure. I'm not quite certain why it things, because it certainly, like Dr. Kircik and I, this was part of my training as a resident. We talked about it and why it was important. I think I got lost probably because we had a number of different topical things that we thought were the be and end all. We could just use the topical retinoids, we could use the topical steroids, and everybody get better regardless. But that, we know that's not true. We have to use everything in conjunction. And Leon, do you have an idea?
I think one more thing is that, yeah, I have an idea, and it's totally my personal opinion. I might be totally wrong, but in US, we have lost the art of compounding. You know, in dermatology, when I was a resident 30 years ago, 50% of our prescriptions were compounding, concoctions. All the old timers made it. Well, guess what? Now, if I give a compounding prescription to a patient, they go to the Walgreens or CVS's, they absolutely have no clue. I have to get 20 phone calls, and also the insurances usually don't pay for it. So I think that sort of caused that slowly dwindling the compounding prescriptions, including the acid mental.
So what? But why didn't pharmaceutical companies think about it? You know, people that make CeraVe obviously came up with the right idea.
Oh.
So another interesting question is,
that's a good question.
Is all itchy skin dermatitis, and so is CeraVe may help?
Well, there are many different types of dermatitis. Dermatitis per se basically always has a barrier defect going on, whether it's nummular dermatitis or atopic dermatitis. And certainly moisturizers are often the mainstay for whether you have it on your arms or your hands or your feet or whatever else. Different moisturizers are very important.
I agree.
One question, what would you think of aluminum acetate?
I am not familiar with it.
Have you ever tried mixing it with steroid to get skin moisturizer and treat at the same time? So that's a bit of the compounding we talked about.
Yeah.
Again, in the old days, we used to do it all the time, but not anymore.
Yeah, it's difficult. It's certain. There's no contraindication. Certainly, if you mix tar, you mix a little bit of steroid into, or you split it half and half, they go in. But it's not usually recommended, particularly with CeraVe, because you got this special formulation, and you might cause some of that to break down. So I think it'd be better to use your topical steroid and use your proper moisturizer in conjunction with it.
Do you think pH is relevant to rosacea?
I do. Yeah, I think it's you know, the paper that we wrote, we just in terms of constraint and amount of time doing it and everything else, we reviewed the literature on atopic dermatitis and acne. But yeah, had we enough time and everything else and enough energy, rosacea, I think, is probably part of the answer. You know, we also looked for literature. There's actually a surprising paucity of literature surrounding this particular concept. Nobody's kind of working on it right now that I know of. And I think that sensitive skin that you're seeing with rosacea is because that pH is higher and the skin is more inflamed. And I think all the more importance in rosacea to use the proper cleanser and the proper moisturizing agent.
Actually, there are studies that shows that when you use the gentle cleanser and the moisturizer with rosacea treatments, the patients do better, just like the acne studies.
So this is a question that comes up a lot. Do we apply steroid to AD first, then cover with moisturizer, or the other way around?
Leon, you take that one.
So that's $1 million question. And the way I'm going to answer it, that if the medication, regardless of steroid or calcineurin inhibitor or PD4 inhibitor, if you think it's going to irritate the patient, because sometimes the patients cannot tolerate that medication, it stings and burns, it is better that you apply the moisturizer first and then apply the medication. And inherently, we think that that's wrong because you always want to apply the medication first and then put the occlusive moisturizer on it to make sure that the medicine is going in first. But in clinical studies, and not with atopic derm, but we did a study with tazarotene and CeraVe actually in acne, and tazarotene itself is very irritating. When you apply the tazarotene first, and then when you apply the moisturizer, CeraVe moisturizer, it didn't do as well as when you apply the CeraVe first and tazarotene later on. And there was no difference in clinical efficacy, but the tolerability is much better when you apply the moisturizer first. And I think that's overall the principle is the same. If you have a prescription medication that is difficult to apply and tolerability is not as good, it's stinging and burning, use the moisturizer first.
Yeah, Dr. Kircik, I agree. There's actually a study about crisborol, and you actually, if you put on the moisturizer first and then the crisborol, you actually are diluting the crisborol. However, you're increasing the adherence greatly. So exactly what you said, it's better to get that adherence, getting the patient to use this stuff to get it better, rather than them putting it on and going, oh, I'm not going to use this, let's try something else.
So in this time of COVID and of course face irritation because of the use of masks, is the appropriate level of pH important in a moisturizer and cleanser?
I think it's all even more important. We're seeing a lot of irritation because of people having, particularly in healthcare workers, dentists, but you know, everybody's wearing a mask. So people that maybe a hairdresser, people that are your greeters at the a Costco or Walmart are wearing masks. Everybody's getting a lot more irritation. So I think it's even more important to be using a proper moisturizer and wash.
But more importantly than the moisturizer, how about more importantly than the mask, what about the hand washing? We are washing our hands several times a day, not only healthcare workers, but everybody else, because everybody is freaking out. And we're using these disinfectants with a lot of alcohol in it. With all these sanitizers that we're using, it's really #1 enemy for the epidermal barrier. So it becomes much more important to use a low pH moisturizer than anything else to restore that epidermal barrier back with the excessive hand washing with the sanitizers.
Here's a nice comment from Dr. Nache. He's have found that skin lipids and many people on statins also become itchy. They seem to do well with CeraVe moisturizers. So that's another point of view. And then finally, as a last question, how does the multivesicular emulsion play a role in CeraVe?
So that is basically the whole principle that is sustained release. These little bilayers of the little vesicles, they open up slowly one by one as the time passes by over 24 hours rather than over 4 hours compared to a regular emulsion or traditional emulsion. So here you have sustained release of the ceramides and the other lipids and all the other ingredients slowly but surely over 24 hours, where you are continuously moisturizing the skin over 24 hours rather than over 4 hours in traditional moisturization.
So we'd like to thank you all again for joining us this evening for our Skin Chat webinar, and also to our speakers, Dr. Kircik and Dr. Lynde, for always a wealth of knowledge. And finally, of course, we would like to thank our sponsor, CeraVe, for making this educational event possible. So thank you again, everybody, and have a good evening. Bye now.
Bye, everybody.
Bye. Good night.
Bye.